Okay, good afternoon, everybody. Thanks, Dr. Vineet, for chairing this session. Akhil will join us very soon, I suppose. But for people in the audience who have not heard about enfortumab vedotin, since this is a very heterogeneous audience, I thought I'll tell you about what that is before we get into the panel discussion. Enfortumab vedotin is a antibody drug conjugate. So a couple of decades ago, we started with targeted therapy. And then from targeted therapy, we went on to immunotherapy. The last decade was full of immunotherapy. And now I think that this decade is going to be the decade of antibody drug conjugates. Okay. So what does it do? It has a carrier, and then there's a toxin or a molecule that's sitting on that carrier, which is then targeted to a particular protein or a moiety on the cell surface. For enfortumab vedotin, the receptor that it is actually targeting is called nectin-3. Okay, nectin-3 is the receptor that it is targeting. The toxin that it is carrying is called monomethyl auristatin E, MMAE. Okay, so nectin-3, monomethyl auristatin E. So that's what it's carrying, and that's how it goes and causes whatever cytotoxicity it drugs. So our panel discussion here is going to be on third-line treatment in urothelial cancer, because that's what we are supposed to talk about today, though the molecule has actually moved up in terms of its usage, but that's what we will do today. And I'll take the liberty of asking Dr. Vineet also to be on the panel to answer, not just to chair. That's a disclaimer. So here's a 64-year-old male, hypertensive, coronary artery disease. He's got Lynch syndrome. So all brothers have some Lynch syndrome related cancer. So this gentleman underwent a subtotal colectomy for ascending colon cancer in 2009, Whipple's procedure for a periampullary carcinoma in 2016. He's been on very strict surveillance, so everything is picked up relatively early, so did not need any chemo as such. He underwent upfront left radical nephroureterectomy with a bladder cuff excision for a mass. How did it move? Okay, for a mass in the renal pelvis in October 2022. So he's got a carcinoma of the renal pelvis. Akhil, you can join. Right, so the pathology was a T3N2, high-grade papillary urothelial cancer, indeterminate lymphovascular invasion, 3 out of 7 lymph. Why is it moving? It's okay. 3 out of 7 lymph nodes were positive, and there was extranodal extension. So, Akhil, we are talking about a gentleman with a family of Lynch syndrome, subtotal colectomy done, and then Whipple surgery for periampullary carcinoma done. And then now he has had upfront left nephroureterectomy with bladder cuff excision. T3N2, high-grade papillary, started on gemcitabine and cisplatin. He had a very stormy course, so it was stopped at 3 cycles. An MRI of the abdomen was done post 3 cycles, which was just showing some post-surgery changes. It was absolutely fine. So this is his MMR done on tissue. It's showing an MSH2 and an MSH6 loss. Typically what you would want to see as a pair when it's lost in patients with MMR deficient disease. And he also had a foundation 1 testing done. It's got a plethora of molecular changes. Anyway, for you, the most important one is that MSI is high. The tumor mutation burden is 42 mutations. The PDL1 is 30 CPS, and you also see an MSH2 that is mutated. Okay, so T3N2 urothelial cancer, intolerant to gemcitabine cisplatin, took only 3 cycles. So the question is, should we use adjuvant immune checkpoint inhibitor in this patient, or would you not? Okay, let's start with you.
He would be very happy to utilize adjuvant IO.
Absolutely. So, absolutely.
And the disease burden is also high, and the patient is not feasible to give 1 more cycle of chemotherapy, which we usually try to give, but here we saw that the patient's stormy course. So it seems that this is a group where we might not have very clear answer, but I feel that these are the situations where it might be the best scenario to give adjuvant IO to reduce the chances of recurrence.
Excellent. So all of us agree with that. Excellent. So we all agree. So we generally, irrespective of whether you've got the features that you're seeing on the screen or not, immune checkpoint inhibitor is approved for use. It's recently read out to be an overall survival benefit also with nivolumab for a year. But this patient is a dream patient for anybody who wants to use an immune checkpoint inhibitor. MMR deficient, MSI high, tumor mutation burden, CPS, all the best markers for an immune checkpoint inhibitor efficacy is there in this patient. So it's a dream patient. But the problem is all our dreams don't come true. So he had an immune checkpoint inhibitor. He had nivolumab. In fact, his brother, who had a high-grade neuroendocrine tumor, advanced disease, PRRT, nothing worked. He was on Pembro, and he's now disease-free 5 years after a high-grade neuroendocrine tumor. So this gentleman also wanted to take Pembro because his brother did well on Pembro, but then we said the data in bladder cancer is for Nivo, so we will give you Nivo. After 3 months of nivolumab, you see that there's disease all over the place. There is peritoneal disease. There's a deposit in the latissimus dorsi. There are some indeterminate mesenteric lymph nodes. So this is 3 months post nivolumab, 6 cycles, 2 weekly. Rishabh, what do you want to do now? Correct. That will not change your management. So would you want to do a rebiopsy on this? Because he's got a...
we would do the biopsy because they do have specific because of this.
Okay, T3N2 to start with, florid relapse in 3 months. They have a tendency to have new malignancies, but we are not doing it in this situation. Yeah.
Sometimes there can be flare up with immunotherapy in initial few months.
He's symptomatic. There's disease all over the place. From no disease to flaring up is not something that we will see. From persistent disease to a little increase is something that we can see, but you don't see disease in the latissimus dorsi and, you know.
So it's not pseudo-progression.
This is not pseudo-progression.
That is a frank new disease.
It is frank new disease.
New disease can happen. New lesions can still happen.
No, new lesions can happen, but you don't have a clean scan becoming a dirty scan after immune checkpoint inhibitor. Okay, and
definitely that is not feasible. That is not explainable actually.
And pseudo progression in bladder cancer is extremely rare. We all like our patients who have bad scans to be labeled as pseudo progression, but please remember that it is very, very uncommon in bladder cancer. Most progressions are actually true progressions. Melanoma, to a certain extent, kidney cancer, this is where you see pseudo progression, not in the other areas. But anyway, it's a point very well taken. Okay, so we did a rebiopsy in this patient. The rebiopsy with immunohistochemistry showed that it was the same old disease that has come back. Rajat, what next? Taxane, enfortumab vedotin, sacituzumab govitecan, that's another antibody drug conjugate, or do another NGS.
This is not a typical scenario that we see in our clinical practice. So what I would be...
That's why this patient is on a panel discussion.
So what I would be inclined is, considering that it is, Lynch syndrome, I would give Pembro plus EV to this patient.
You would give Pembro plus EV.
Tempted to give IO, and also I would give EV. This is what I would do.
So what is the logic behind giving Pembro? We'll come to EV in a moment, but what's the logic in giving IO? Because
there is, I think, there is logic behind, there is not much logic behind giving everything apart from EV and probably taxane, but it is not a typical scenario, and it is very surprising that why IO didn't work. So we know that there is a lot of, I know this is not a academic discussion, but sometimes we don't get a proper drug quality also. So
No, that's very good quality BMS. So it's not some local Bangladesh make. Okay, so you can see that if somebody had combination medicine,
That news that most of the contamination was in the original drug also. They were given the same DMS vial with a drug.
okay, let's not get into
So,
that. So let's not get into that.
that.
Okay, you will give pembrolizumab. Okay, we'll give it to you. Okay, so for the audience, though Rajit is saying what he thinks is the best thing, when somebody progresses on an IO, and that too rapid progression like this, in general, we would not want to add another IO. In fact, there's successive sets of data in all malignancies now that if somebody progresses, adding, immediately, let's say they come back with disease after a year or so, then it's okay to do. But if they're progressing on the treatment, to add or change to another IO actually doesn't get you anywhere. But it's okay, Rajat, we'll give it to you. Dr. Vineet, what would you do in this situation?
It's a very clear case. There's a family of
Correct.
and
It happens. So Rakesh sitting here is the surgeon. So he is testimony that this case actually exists. So he's the one who operated.
What I'm saying is that 3 months it's not
True progression.
and also
Correct.
the bad
Bad disease rather.
as far as the prognosis is concerned.
Right.
So if you go by the
You would give him enfortumab. Okay. You would give him enfortumab. Rishabh and Akhil, enfortumab. Okay.
That's the best
Super.
possible.
Okay. So that's exactly. So I think you've got the older set of slides. That's all right. Never mind. So this is EV301, which is what Dr. Vineet is actually referring to. So these were patients who had actually progressed on chemotherapy and progressed on an immune checkpoint inhibitor. So when metastatic bladder cancer patients usually progress on chemo, they go on to get an immune checkpoint inhibitor. And then when they progress on an immune checkpoint inhibitor, this is what is the treatment of choice, at least at this moment. So what this trial did is randomized patients who progressed on both of these treatments to enfortumab vedotin, the drug that we just discussed, versus investigator choice of therapy. And the investigator choice of therapy here was a taxane, which could be either docetaxel or paclitaxel, or another drug called vinflunin, which is available only in some parts of Europe. Okay, it's not a widely used drug. In this study, about 30% of patients actually went on vinflunin. So Akhil, you're happy with the randomization? This should be the standard of care because you discussed about poor control arms in clinical trials. Is this fine? Are you acceptable with this?
Yes, this seems to be a standard treatment which patient has already received.
Very
So
good.
Be happy with this design that patients have already received the previous treatments, including platinum and immunotherapy.
Excellent. We are all happy with the control arm because that's typically what would be the go-to for all of us in a situation like this. And even more importantly, the primary endpoint was overall survival. In most of the studies in metastatic setting today, you get DFS as the endpoint. Here is a study where you're getting overall survival as the endpoint. So we're very happy with the way the study was designed, including the endpoint. Okay, so you come to the bottom of this slide. So if you see response to immune checkpoint inhibitors, 70% of patients who went on to the EV301 did not have a response at all to their second-line immune checkpoint inhibitor, which is what the case usually is. The response rates to second-line immune checkpoint inhibitor is roughly around 22-23%. To second-line chemo is around 12-15%. That's typically what you would get. So it's a very difficult set of patients to treat. Okay. Rajat, are you happy with the overall survival? It's improved the overall survival by 4 months. So that's about 9 months to nearly 13 months. A hazard ratio of 0.7. Happy with this?
So definitely considering it's given after platinum and IO, so it's a very good data for a third line setting with a very good hazard ratio.
We are very good with the overall survival. Rishabh, you're also happy. Early separation in 3 months in terms of survival. P-value is good. Okay, so you're saying it's a statistically and a clinically significant result in terms of overall survival. So it reduces the risk of death by 30% compared to chemotherapy alone. So that's a treatment that one should consider in this setting because there's an improvement in overall survival. How is this important, Akhil? the response rate to EV is 41% versus 18.6% in patients with chemo. Is response rate an important parameter, or one would consider just overall survival to be the most important factor?
Bladder cancer and other head neck cancer, these two are the cancers where the symptom burden is too high for the patients. So symptom control is dependent on response rates, to be frank.
Absolutely.
So it's not only the overall survival which is important, it's the symptom control which I talked about, quality of life being important. Quality of life will be improved when symptoms.
Absolutely.
Symptom will be controlled when there is a response.
So it's very important for us to look at the response rate, especially in certain situations where patients come with lots of disease, they're highly symptomatic. So if a treatment gives you higher degree of response, there's a higher probability that your patients will get good symptom control, and that will certainly result in good quality of life. Okay, so our patient was started on enfortumab. The scan on the left is the scan done in April. The scan on the right is the scan done in June. So this is after 3 months of enfortumab vedotin. You see that there's nearly a complete response. That scan shows that almost all areas of disease have disappeared. It's not a complete response as you're seeing on the PET. There was a near complete response, should I say. Now, this is one of the major concerns that people have voiced when it comes to enfortumab vedotin. So, Dr. Vineet, let me ask you, how bad or how difficult are the toxicities? What are the toxicities that one should look out for? Because that's very important so that we keep our patients on treatment, do the right things at the right time. Dr. Vineet, which are those toxicities that you're concerned about?
All of us see living our there's so
Very good. Excellent. So these are, so whenever we get a new drug, they come with some new problems. So we all will have to learn the toxicities of this new drug, make ourselves aware, and also make our patients aware of the toxicity so that they will come back and report to us on time. So like Dr. Vineet said, sensory neuropathy, rash, these are two very, very important ones. There's something that is less common but important is the ocular toxicity, right? So they can get corneal, decompensation, corneal ulcers, dry eye. These are very important. In fact, some people would say that use prophylactic, tear substitutes to begin with so that the incidence of this is a little lesser. The other thing that you sometimes see is sugars going up also. Now, Rishabh, let me ask you this question. Again, whatever Dr. Vineet mentioned is on the left. This is the median time, okay? This is the median time to occurrence of these disorders. Why is it important for us to know the median time at which these things happen? Okay. Okay.
Longer time there. So if some toxicity are very aggressive, for
Okay.
So how can especially if there is a precursor for toxicity and if we expect some toxicity under control, we see there is a try.
Okay. Rajat, anything to add?
I think also we can consider involving our fellow colleagues if we know that at this time skin toxicities they are bound to happen, or ophthalmic toxicities they are bound to happen. We can probably ask the patient to consult an ophthalmologist at that particular time and consider following it with that doctor.
Okay. Okay. These are two very important points involving your other specialty colleagues. But one very important thing is that you should know when these toxicities are likely to occur in your patient. For example, you don't want to look at ocular toxicity 15 days after your patient has started on the drug. If you know the average time at which these toxicities are likely to happen, you will be more vigilant and look for these things at that particular points in time. For example, if you see this slide, the majority of the toxicities, the median time to occurrence happens somewhere in the 2 to 4 month range. So you will be maximally vigilant in the 2 to 4 month range so that you won't miss any of these major toxicities and then let it reach a point wherein your patient's quality of life has been compromised because of this. You have to stop and so on and so forth. So knowing unique toxicities are important. Knowing when they are likely to occur is also very, very important, because you look at this slide, there is a 1/3% of patients who will need dose reduction, half of all patients who will need dose interruption, and 1 in 6 patients who will discontinue the drug. Okay, so if you want to keep your patients on the drug, do the right things, then you need to know what the toxicities are and when they are likely to happen. And this is why, if you do the right thing, then your quality of life on the drug is also likely to be better. So let's come back to our patient. So we said EV gives you better overall survival. There are some unique toxicities. There's better response rate, twice the response as what you would get with chemotherapy. And then the toxicities that occur at various median time points. So the scan on the left is June 2023. Scan on the right is done in September 2023. So that's roughly after 3-4 months. So you see that the deposit in the latissimus dorsi is now starting to increase in size. All the other things are under control, and only that deposit has started increasing in size. So again, biopsy, because we always don't want to miss something else in this patient. Of course, this time we didn't do an immunohistochemistry. It said metastatic poorly differentiated carcinoma. So what shall we do? Taxane, sacituzumab, RT to the progressing site and continue EV, repeat another NGS. What shall we do? Rajat? Or anybody.
This patient is responding very well to EV and there is only single site of progression. So although all the 3 are valid options, but my take would be give radiation to that site and continue with EV.
Excellent. All of us agree with that? Lovely. So that's what we did. So we just did some radiation to the latissimus dorsi deposit. And then, as you would expect, this patient did well. That deposit disappeared. And then 4 months later, another scan. So scan upon scan, the result was good radiation, I suppose, to treat this patient. So, and then you see that the scan is now clean. This was in December. This patient has had another scan in April, but that's an abdominal CT scan, which tells you that it's still very much under control. So he's had a good run on EV. So, Akhil, let me ask you 2 questions here. One is, now we're talking today about third line. Now our first line treatment for bladder cancer has changed. At least in our country, most patients would go on Gemcis followed by avelumab maintenance. So do you think that this data that we've just shown is valid for a patient who's been on avelumab maintenance also? That's one question. The second question is, if somebody had an FGFR alteration, what would you do? Would you do EV or would you do, one of those FGFR targeted therapies, let's say edrafitinib or one of those? What would be your answers to both of these questions?
It's important to understand that this data is very clear, at least post chemo and post immunotherapy. I don't think there is any doubt. It might be any immunotherapy available. All these drugs have nearly similar mechanism.
Correct.
So there is no doubt that EV data can be definitely utilized post avelumab.
Excellent. Very good.
Only thing is that if patient has been post 1 year of Gemcis, was doing well on avelumab for a year, there is an option to re-challenge on Gemcis. That is an acceptable option.
Excellent.
So that
Very
can be dependent on the patient choice and the previous toxicities to the treatment.
Absolutely.
Second question is about FGFR. So if a patient also has an FGFR mutation, FGFR fusion, I would like to see which FGFR fusion, what is the data of response to that particular fusion? Because here we'll be doing a cross-trial comparison,
Correct.
but we cannot do away with cross-trial comparison in medical oncology anytime. So if I feel that the response rate is better with EV, I will be more than happy to utilize EV, because it seems to me the response to FGFR inhibitors is there, but it's not so great.
Okay.
That is my personal experience. It might be variable, but EV has definitely a very good data set. So I will try to again look at the data for both and will cross comparison it. I think you might highlight the trial data for it as well, so that if we
you can. You want me to do it? Okay, I will do it. Dr. Vineet, what would you do if you find an FGFR fusion, a tablet versus an injection? Would you have some choice based on that, or is just based on data? So have I. I think Akhil has got some experience.
Fusion inhibitors on compassionate access in a significant.
Yes, I have not had any experience, right? Either of them.
Patient preference, as you just highlighted, it is an injectable drug, another is a tablet. So that
Correct.
becomes very important when we are counseling the patient. And it is the patient
Correct.
choice which will also highlight. But at the same time, we'll provide the data. What is the response in one study? What is the data in another study? Because most of these patients are literate, well-read. They do come after Googling everything. And you have to be very well.
We have to ready for the Viva whenever they come to us.
Correct.
Correct. I understand. Yeah. Yes. Correct. Immunotherapy. Yes. So all points very well taken, that if this patient has, you need to look for targets. Unfortunately, at the time of diagnosis, he did not have an FGFR fusion. So the question, just to put into perspective for people who are, in the audience who are not generally managing patients with metastatic urothelial cancer, one of the targets that we always look for is an FGFR alteration, because FGFR alterations have drugs which can target these alterations, and one of those drugs is called edrafetinib. Edrafetinib is not yet available in India. It's obscenely expensive. If EV is expensive, it is, EV ka baap. So that's how edrafetinib is. It's very unlikely that our patients at this point in time, at least a significant proportion, will go on the drug. So to the question that I asked, if you find an FGFR fusion, what would you do? Both EV and FGFR are anti-FGFR drugs are absolutely fine. Akhil spoke about response rates. In the edrafetinib study, the response rate was roughly around 35%. But the other most important point that he made should never be forgotten. Look for what FGFR alteration it is, and then check whether your drug will work or not. Just like we said, all HRR mutations are not the same. All FGFR alterations are not the same. So check that always. So it's a 35% response rate. The overall survival is absolutely the same as what you get with EV. It's about 12 months. The delta for overall survival is absolutely the same as what you get with EV. It is the same 4 months. Okay, so 35%, 12 months, delta of 4 months, a hazard ratio of 0.64, slightly better than EV in that setting. Okay, EV is 0.7, it's 0.64 for edrafetinib. But there's a nice analysis from the UNITE database. What I'm showing you on the screen here is from the UNITE database. There's another analysis from the UNITE database that was in ASCO GU this year, which tells you that the sequence does not matter. If you use, but it's a small set of patients. Obviously, you won't get a huge set of patients where you have done the sequence in a randomized fashion. But based on the available data, whether you start with EV and end up with edrafetinib, or whether you start with edrafetinib and end up with EV, it doesn't matter. The overall survival is roughly around 20 months. Remember, it's 12 months here. When you do both the treatments, it comes up to roughly around 20 months. So it seems that the effect is actually additive there. So just like Akhil and Dr. Vineet said, you need to discuss these numbers with your patient. Yes, Dr. Vineet, you want to say something? Correct. Yes, yes. This is correct. So real world data has its own biases, and you're absolutely right when you said that not all patients will go from one to the other, but you make sure that you're following them up very closely and do the change at the right time, as Akhil was emphasizing in the previous panel discussion, the right drug for the right patient at the right time in the right sequence, which is very important now. So make sure that you don't forget that there is a targeted therapy that is available, and that if the targeted therapy is available for your patients to access, then it might be worthwhile putting them on that targeted therapy. But the point that Dr. Vineet is making is very clinically relevant. In urothelial cancer, when you move from one line of treatment to the other, nearly it's like the old movie, correct? Movie theaters of our era, where they will ring this bell if the interval is there or if the movie is getting over. When the climax is on, so they will ring the bell, and then the AC and the lights will go off also, which is probably not happening today here. So the attrition rate with every line is higher in urothelial cancer compared to many other cancers. So that's the point. It's very important, clinically relevant. So our patient continues to do well. As of April 2024, this is his scan. Let's see how the good run is and how long the good run will be. So for people here, EV is going to be available very soon in our country. And if the price is reasonable, then we will all have some patients on these drugs. And then when we meet next time, we'll probably share more experience as far as EV is concerned. Thank you so much for that hearing. And thank you, panelists, for being so good.
Thank you.